Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
I'll be presenting on the CTS-AMI randomized clinical trial today. And before we get started here, I wanted to take this time to go over some background and literature review. So with cardiovascular disease in general, in China, there is roughly 330 million individuals affected, which is essentially the entire population of the United States. This really accounts for about 40% of all deaths in China, and common risk factors that we see are similar to that in the United States, such as obesity, dyslipidemia, hypertension, and diabetes. I do want to point out there is a difference, a rather large difference in obesity between China and America. And the way that this study at least defined obesity was really in terms of waist circumference, measuring more than 85 centimeters, which is about 33 inches or a US size 16 pant. CVD in China does remain the number one cause of death in that country. To kind of juxtapose that to cardiovascular disease in America, there's roughly 20 million people affected, or about 20.1% of all deaths in America. Rates of obesity, hypertension, and diabetes, I would say, compared to that of in China, are significantly elevated, and it does still remain as the number one cause of death in America. Moving to the star of today's discussion, Tongsin Lu, which is going to be called TXL throughout the rest of this presentation. TXL is a medication that has been used in Chinese medicine for many years. It was first approved in 1996, but I wanted to take a closer look at the composition here and really dive into that more than 80% of TXL is made from a mixture of Chinese leech, cicada, scorpion, and ground beetles, the remainder being composed of different herbal supplements. In China, again, it was approved in 1996 for angina and for aspirin resistance and ischemic stroke. It's also been studied in cardiac X syndrome, which, for a little bit of background, is angina-like chest pain, where there's evidence of myocardial ischemia in the absence of stenosis. And although it has been approved for use in China in 1996, safety and efficacy data really weren't fully evaluated prior to its approval. For a little background on the actual wording of itself, Tong means to open, Luao means the network, and Xin means of the heart. So the full name of it means to open the networks of the heart. But in general, it's been more recently studied in acute myocardial infarction, which is where we will dive into that today. But prior to diving into today's article, I want to first talk about some historical literature with TXL use in China. So the CAPITAL trial is a randomized, multi-center, double-blind, parallel group, placebo-controlled trial that was published in 2019 that aimed to assess whether TXL can slow progression of carotid atherosclerotic lesions, which they measure using a focal intima media thickness of the carotid arteries. The study was able to show that an annualized difference in change in the IMT was roughly negative 0.014, and that was a significant finding. However, what does that mean clinically? So looking further into that, it looks like, based on my review, IMT is used in diagnosing the extent of carotid atherosclerotic vascular disease, which could potentially allow for more timely interventions. However, the AHA did examine the value of measuring INTs in 2009 for predicting cardiovascular risk, and they concluded that it can independently predict coronary and stroke risk in middle age to older adults, but it's relatively modest and inferior to that of just doing a carotid plaque analysis. So not necessarily sure the clinical significance of this statistically significant endpoint. This study was a systematic review examining TXL in standard of care for unstable angina. This review included 18 randomized controlled trials accounting for roughly 1,400 patients. Overall, the studies did not show a strong support of a benefit of TXL for reducing the combined outcome of acute myocardial infarction, PTCA, or CABG. There were some statistically significant benefits shown in the reduction of angina attacks and overall symptoms. And the last trial we'll talk about before getting into ours today is a systematic review and meta-analysis of 18 randomized controlled trials that included over 1,400 patients, where the main aim was to assess the effectiveness and safety of TXL with aspirin versus aspirin monotherapy in aspirin-resistant ischemic strokes. With the primary outcome that is assessed here, 15 of the randomized controlled trials were evaluated for this platelet aggregation rate compared to aspirin alone, and they were able to find a significant difference, but again, wanted to look into the clinical significance of this endpoint. And the American College of Cardiology actually released an expert analysis on this in 2016, speaking on platelet function testing, and they ultimately concluded that the utility is limited to research purposes at this time, and that specific patient populations where a benefit has been determined is currently unknown. So moving into our topic today, the CTS-AMI randomized controlled trial. Starting with a brief overview of the journal and authors, this piece was published in JAMA, which is the most widely circulated general medicine journal worldwide. And Dr. Yuan Yang is the primary author. He's an interventional cardiologist by training and works at the Fuwei Hospital, which is an approximate 1,200 bed hospital in Beijing, China, known for prestigious work in cardiology. He also has over 400 different publications, all of which are cardiology related in nature. The main objective of the study was to investigate whether TXL could improve clinical outcomes in patients with STEMI. And it was a randomized, double-blind, placebo-controlled, multi-center trial that took place at 124 different clinical centers in China. It was conducted through May 2019 through December 2020, with the last patient follow-up being December of 2021. Inclusion and exclusion criteria are listed on this slide. This is not an all-encompassing list, but inclusion criteria were those adults aged 18 and up, those who presented within 24 hours of MI symptom onset, and also those who had ST elevation. The exclusion criteria list is not all-encompassing. However, I wanted to highlight some more prominent ones, which you see listed on the slide. Mechanical complications in this study included interventricular septum perforation, papillary muscle rupture, chordae tendineae rupture, or ruptured left ventricles. Based on previous literature, it is known that through an unknown mechanism, TXL can exhibit antiplatelet effects. So they did exclude active hemorrhaging, but wanted to point out that in their exclusion criteria, or rather the definition for active hemorrhaging, this also included individuals who were just menstruating. So this may limit otherwise perfectly acceptable contenders from the study. Other exclusion criteria I wanted to briefly note were those that had critical illness due to STEMI. However, it was unclear in the definition of that what that truly meant, because they did include cardiogenic shock patients. It's unclear as to what objective data may have went into determining the severity of critical illness for the study. As far as randomization, there were 297 patients excluded, leaving 3,797 randomized in a one-to-one fashion to either receive TXL or placebo. And of note, the total number does vary slightly from the intention to treat population versus the per protocol population. The dosing strategy utilized in this study is shown on the slide. Of note, this study did require a 12-month follow-up for full results, and the maintenance dosing of 4 capsules TID was continued for the full time frame. They did require, in order to meet the intent to treat analysis, 80% adherence. I was just kind of taken aback at first by this dosing scheme, as I think we can say that this is a significant pill burden, at least, especially from a 12-month period, in addition to the onset of GDMT in these patients. Primary outcome was major adverse cardiac and cerebrovascular events at 30 days, which were cardiac death, myocardial reinfarction, emergent coronary revascularization, and stroke. Secondary outcomes are listed on the slide. Some ones that I'll touch on: severe complications included acute left heart failure, mechanical complications, which we talked about previously, and also malignant arrhythmias or arrhythmias that were not responsive to antiarrhythmics. Major bleeding was defined as through grades 3 through 5 on the Bleeding Academic Research Consortium. And instant thrombosis was evaluated throughout multiple time frames of the study: less than 24 hours, 1 to 30 days, and 1 to 12 months. As far as statistical analysis, there were roughly 1,900 patients in each group that was required to meet power. I will say this was met in the intent to treat population, however, lost in the per protocol population. Cochrane-Mantle test was used to make risk ratios and risk differences. All other statistics used in the study were rather standard. Moving on to the results. So for baseline characteristics, they were overall similar between groups. The average patient in this study can be classified as a 61-year-old Chinese male with a Killip class 1 heart failure after STEMI. For context, the Killip classifications are used to quantify the severity of heart failure in ACS and can be used to help predict 30-day mortality as well as some in-hospital mortality as well. Class 1 is going to be your least affected or your least impacted, with an overall mortality or 30-day mortality rate of around 2 to 3%. Not included on this table are risk factors like hypertension, smoking status, hyperlipidemia, diabetes, and past medical history like stroke, angina, PCI, prior CABG, but those were all similar between groups. As far as guideline-directed medical therapy, I wanted to highlight the use of it in the study. Briefly going over our P2Y12 inhibitors, the majority of patients did receive ticagrelor. However, I did find it odd that no individuals were prescribed prasugrel in the study. And I do want to take the time to highlight our bread and butter guideline-directed medical therapy treatments, which is surprisingly low in this study. Only around 63% of patients were prescribed beta blockers, around half prescribed ACE, ARBs, or ARNIs, and very few patients prescribed SGLT2 inhibitors, and rather low aldosterone antagonist therapy as well. The primary outcome occurred in 3.4% in the TXL group versus 5.2% in the placebo group. This did show a significant risk reduction of 0.64. As individual components, cardiac death and myocardial reinfarction were both significantly lower in the TXL group compared to placebo, with a risk reduction of 0.7 and 0.35 respectively. Looking at 1-year MACEs, looking at our Kaplan-Meier curve, you can see that by month 12, there was a 5.3% incidence in the TXL group versus an 8.3% cumulative incidence in the placebo group. And of note, this finding was significant in the study. For secondary outcomes, many were insignificant findings. The largest secondary finding, as we previously discussed, were the 1-year MACE events, which showed significant reductions in both cardiac death, myocardial reinfarction, and stroke. There were no significant differences in other secondary outcomes analyzed, including ST segment resolution, which was analyzed anywhere between 2 hours, 24 hours, and 7 days after reperfusion therapy, and myocardial reflow as seen on an ECG after reperfusion therapy. As far as the subgroup analysis, there were many variables that were assessed in the subgroup analysis, and all of them trended towards favoring TXL. However, very few of them met statistical significance. Significant differences that were seen in subgroup analyses I have listed on the slide: male sex, a quick onset to arrival time, those with an anterior MI, Killip class 1 and 2, those where GDMT were actually omitted. Adverse events in the study, the patients with any reported adverse events were incredibly high at 96.6 versus 96%, even in the placebo group. And it appeared that the majority of these adverse events were GI related, nausea, vomiting. So in the nausea category, as described in some of the supplements of the study, this capsule, especially when open, may be malodorous. More serious adverse events listed on the slide, like allergic reactions, hepatic injuries, renal injuries, hemorrhages, were all relatively similar between groups. The authors concluded that as an adjunctive therapy, TXL significantly improved both 30-day and 1-year clinical outcomes, but they say that there's further research needed to determine the mechanism of TXL in STEMI. On to my favorite part, the critique. What do I think of the study? So briefly highlighting some strengths of the study. Study design was able to increase its internal validity. And although low, the study did utilize a combination of European and American guideline-directed medical therapy, which may be able to help increase its generalizability. As far as limitations, I wanted to limit the slide to 3. Some of the ones I wanted to highlight include this medication has 12 active ingredients and an unknown mechanism of action, which is drastically more active agents than any combination product that we've seen studied and approved for in the United States. And of these 12 ingredients, it's really unknown how they work in the population, which ultimately decreases, I would say, both internal and external validity. Secondly, there were poor rates of GDMT utilization in the study, and it's really unknown if higher rates of GDMT alone would prove more beneficial than the addition of this medication, TXL. And lastly, all of the patients analyzed in the study were Chinese, so that does limit the generalizability to other ethnic groups at this time. Overall conclusions for the study is that the medication as it is now is really going to be limited to use in China. I agree with the authors that further studies are warranted in order to determine the full safety and efficacy profile. However, I believe it may be more beneficial to compare the addition of this agent following a stricter adherence rate to GDMT in China. I would say based on the findings of the study and its strengths and limitations, TXL use should not be considered as an adjunct therapy to GDMT in America. And with that, I'd love to hear some of your thoughts, and I would be happy to answer any questions you may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.